Thank you very much, ladies and gentlemen. Thank you, Zoltán, for your kind invitation. And it is my great pleasure to be here and to speak in this symposium about sepsis treatment and research. We know that sepsis and septic shock is one of the more serious conditions. We deal with the ICU, but when you add the coagulopathy in the clinical picture, well, the things can get even more complicated. So that's why I would like to talk about today the coagulopathy of sepsis, which is something we all have faced in the ICU, and it's not always easy to know the best way to manage it. So the sepsis-induced coagulopathy is a common complication of sepsis. It is associated with high mortality, and it is characterized by a systemic inflammation and together with the coagulation overactivation, which is leading to microvascular thrombi and organ hyperperfusion and the subsequent organ dysfunction. So in severe sepsis, the balance of the physiological hemostasis is disturbed, which is leading to a procoagulant state due to a massive thrombin generation, impaired anticoagulant activity, together with the suppression of the fibrinolysis, a condition which is called sepsis-induced coagulopathy. Today, I would like to give you a very short summary about what's actually happening in the body when the sepsis coagulopathy develops, how we can recognize it early, and most importantly, what we should do about it. And finally, I will also touch some of the latest research and treatment options which come down the pipeline. So let's start with the immunothrombosis. Immunothrombosis is natural defense mechanisms against infection. During infection, special particles from the microbial sources releases and activate special cells, such as neutrophils and monocytes, and also platelets and endothelial cells. Monocytes and endothelial cells then release tissue factor and activate the thrombin. And additionally, the activated neutrophil cells release these extracellular traps here, which serves a kind of surface of the contact activation system. In this system, the factor 12 activated and further promotes the thrombin generation. And the activated thrombin then produces the fibrin network, and it is important because this fibrin network are able to trap the bacteria in order to localize the pathogen and prevent its spread into the systemic circulation. However, we need to know that this immunothrombosis here can serve as a double-edged sword as well. In severe sepsis, the dysregulated host response will release a huge amount of pro-inflammatory cytokines, and then these cytokines will trigger a superactivation of our coagulation system, along with the depletion of the anticoagulants due to the endothelial cells injury. Therefore, a massive thrombin generation develops, and this huge amount of thrombin together with the suppressed fibrinolysis produces a very dense and a very resistant fibrin network, which leads to this microvascular thrombosis here and the subsequent organ dysfunction. And so these are the main mechanisms underlying the sepsis-induced coagulopathy, and it is important because we need to gather information about these processes in order to successfully recognize and then treat the condition. So, and one more thing. In our everyday clinical practice, this sepsis-induced coagulopathy is sometimes mistakenly thought to be the same as a disseminated intravascular coagulation, but there are important differences. The vast majority of our septic patients presented with hemostatic abnormalities ranging from subclinical coagulopathy to a fulminant disseminated intravascular coagulopathy, which is also known over DIC. In over DIC, there is a very clear and very significant depletion of coagulation factors, platelets, fibrinogen, anticoagulant, and also the suppressed fibrinolysis. And the manifested clinical picture, whether it is thrombotic or bleeding, depends on the disturbed of the balance of these disturbed mechanisms here. In contrast, in sepsis-induced coagulopathy, which is one of the kind of form of non-overt DIC, it is characterized by an excessive activation of the coagulation, but without the depletion of the clotting factors. That's why the manifested clinical picture is the organ dysfunction due to the microthrombosis and the subsequent organ dysfunction. And it is this observation is the observation that this SIC, this non-overt DIC, often precedes the thrombotic phenotype of DIC. And this observation is very important because it has a clinical significance. So, the clinical significance. Yes. Why? Because we need to identify that patient who are in the thrombotic phase of the coagulopathy. This patient presented with a progressive organ dysfunction against, after, or despite of the resuscitation, together with this excessive activation of the coagulation. But it is important to know that at this phase, there is already the consumption of factors, especially the anticoagulants, but without the depletion of the procoagulant factors. That's why the manifested picture is the organ dysfunction, the microthrombosis, and the bleeding does not occur yet. And it is important. It has the clinical significance because it seems that the targeted intervention, which means the replacement of the anticoagulants, should be used in this very phase of the coagulopathy in order to prevent the progression of the disease, maybe improve the survival rate, but it's important without the bleeding complication. Diagnosing the coagulopathy. In order to diagnose the coagulopathy, a multiply scoring system exists. The system used the patient characteristics and the conventional lab values of the hemostasis. One of the first score is this IST-HDIC score, which was recommended for diagnosing over DIC in patients with different type of diseases such as leukemia, sepsis, or malignant diseases. This score has a very good specificity for over DIC and also a very good predictive value for mortality of patients presented with DIC. However, the problem is with the septic patient, when this DIC score is positive, by the time of detection, it's too late. Our patient is already in an irreversible stage of the coagulopathy, and at this stage, and we cannot find the optimal time frame of this of the targeted intervention. Therefore, the IST-H subcommittee produces another score, this sepsis-induced coagulopathy score, the SIC score. It's very easy. It contains only 3 elements here. Very easy to use, and very sensitive as well. What does it mean? It means that if you calculate the CIC score in your patient, you will have a lot of false positive patients, which means that this score will detect those patients as well who doesn't need any intervention. So this is the main problem with these scores. The CIC score is too early, and the over DIC score is too late. Why? Because the scores include only the parameters of massive thrombin generation, but they do not give us any information about the inflammation, the level of the anticoagulants, or the antifibrinotic system. Just look at the results of this study here. In this recently published study, the authors developed an experimental score using these elements here. And they demonstrated a very good negative predictive value of compensated DIC, thrombotic DIC, of 93% at admission, allowing the patient early stratification of coagulopathy risk development in septic patient. What's the problem? The problem is that although these parameters may give us a very precise characterization of the patient, but they remain the tools of the research, and they are not available for our everyday clinical practice. At the patient bedside, viscoelastic test may be useful as a diagnostic screen of this patient. We know that it has been shown that these tests are able to distinguish between septic patient presented with normal coagulopathy or hypercoagulopathy profile or hypocoagulopathy profile. The patient presented with overdic has a hypo, while the patient presented with non-overdic has a hypercoagulopathy profile. However, these tests are able to detect those patients who has this excessive activation of the coagulation together with the conception of the factors. And which is most importantly, that the transition towards to the hypocoagulopathy profile is a very dynamic process and evolves rapidly. So that's why the timing of the testing can significantly affect the results. Therefore, the sequential measurement may more accurately detect this patient with DIC, may accurately detect the progression of the processes, especially if we combine this viscoelastic test with the measurement of the level of the anticoagulants, could detect this patient and maybe could affect the outcomes as well. So regarding the management, the most important step of the management of any type of coagulopathy is to fix the underlying cause of coagulopathy, because the effective treatment of the primary condition can help prevent or reverse the DIC process. So that's why in septic patient, this effective treatment means the early hemodynamic optimization together with the early source control and the antibiotic therapy and of course the adequate organ support. However, regarding the management of the coagulopathy, while these guidelines not very well off, we know that in septic patient who has only subclinical coagulopathy or normal coagulation, no special intervention is needed other than DVT prophylaxis. We also know that in case of bleeding patients due to the over-DIC, the effective management requires a very comprehensive approach that addresses both the underlying cause of the treatment of the underlying cause together with the immediate replacement of different elements of coagulation. However, what's happening with this patient with CIC or thrombotic DIC? If we approach this question from the pathophysiological point of view, it might be logic to replace the anticoagulants as well. However, the restoration of the anticoagulants in patients with CIC or non-over-DIC has been suggested only maximum as an adjunct therapy in septic patients. Why? Because the results of the recent randomized controlled trial are so inconclusive, and most of them fail to demonstrate the beneficial effect of anticoagulant therapies in this patient. And accordingly, the recommendation of international guidelines are so conflicting as well. Just look at this. If you would like to give thrombomodulin to your patient, you can do that in Japan. However, it is not recommended in Europe or in the United States. So it seems that these interventions, specifically targeting the coagulopathy in order to prevent the progression, are unfortunately lacking. Why? Because the controversy in the results of these studies are due to the heterogeneity of the studies population. We know that sepsis is a very highly heterogeneous syndrome with variable etiology, pathophysiology, disease severity. Of course, the patient who has a pulmonary infection due to MRSA is not the same patient with the other one who has an intra-abdominal sepsis or septic shock due to this pyogenes here. So that's why we can say that one size doesn't fit all, and unfortunately, this holds true for the coagulopathy as well. The treatment with anticoagulants may benefit only this subpopulation, only patients presented with this phenotype with severe coagulopathy and together with the progression in organ dysfunction. It's very important. So that's why the future clinical research should be aimed to improving the diagnostic methods in order to optimize the stratification of patients with specific coagulation phenotypes. And then, when we see this special population, we need to perform new RCTs in order to investigate the effectiveness and the safety of these therapies. And then finally, in the light of these RTCs, maybe we should refine the guidelines for anticoagulants use in septic coagulopathy. Thank you very much for your attention.